Picture this. You are 67 years old. You walk into the kitchen to make your morning coffee, and you stop. You cannot remember why you came in. You stand there for a moment, searching. Then it comes back to you. Coffee. Right. You brush it off. Everyone forgets things. But then it happens again the next morning, and the morning after that. You mention it to your doctor at your next appointment. You tell them you have been feeling foggy, that you forget words mid-sentence sometimes, that names you have known for decades occasionally just disappear. Your doctor listens, runs a few cognitive tests, then delivers the words that change everything. This looks like early cognitive decline. You leave that office with a referral to a neurologist, a pamphlet about memory care, and a fear you have never felt before. Not fear of dying, fear of disappearing, fear of losing the person you have always been, piece by piece, while your body stays right where it is. What your doctor did not tell you, what almost no one tells you, is that what you are experiencing may not be early dementia at all. It may be your medication, certain common medications, drugs that millions of seniors take every single day, drugs that have been prescribed to them for years without question, have documented links to memory loss, cognitive decline, and symptoms that are nearly impossible to distinguish from early Alzheimer's disease. And the most alarming part is not that these drugs exist. It is that most of the people taking them have never once been warned about this connection. My name is Dr. William Harris. I am a geriatric specialist. In my career, I have seen more cases than I can count of older adults who were told they had dementia, who had already started grieving the loss of their minds, and whose cognitive symptoms improved dramatically once a medication was identified and addressed. Not all of them, not always completely, but enough to make this conversation one of the most important ones I have ever had with a patient's family. Today I am walking you through 6 specific medications that research directly links to cognitive impairment in adults over 60. For each one, I will tell you the mechanism, why it affects the brain, the symptoms to watch for, and what to discuss with your doctor if you or someone you love is taking it. And at the end, I will give you a practical framework for having a medication review conversation that could genuinely change everything. Stay with me through all 6, because number 3 is the one that stops most people cold. It is so common, so trusted, so completely ordinary that almost nobody questions it. And number 5 is the one that the research shows is most frequently missed in cognitive evaluations in older adults. Before we go any further, drop a comment right now. Tell me your name and where you are watching from. And tell me, are you or someone you love currently experiencing memory problems while taking regular medications? I read every single comment. Your experience might be exactly what someone else needs to hear. All right, let us get into it. Before I give you the 6 medications, I need to give you one concept. Without it, you might listen to this list and think, my doctor would have told me, my pharmacist would have warned me, surely someone would have said something. Here is why that often does not happen. The brain of a 65-year-old processes and clears medications differently than the brain of a 40-year-old. The blood-brain barrier becomes more permeable with age, meaning drugs that once stayed largely outside the brain can now cross into it more easily. Liver and kidney function decline, meaning drugs stay in the system longer and accumulate at higher concentrations than the original dosing was designed for. And the brain itself becomes more sensitive to certain chemical disruptions, particularly disruptions to a neurotransmitter called acetylcholine, which is critical for memory formation and retrieval. This is not a rare edge case. This is standard pharmacology. Every physician learns this. But the 15-minute appointment does not always leave room for a full medication review, and the cognitive symptoms often develop so gradually that neither the patient nor the family connects them to a pill that has been on the nightstand for 3 years. There is also something called the prescribing cascade. A medication causes a side effect. That side effect is interpreted as a new medical condition. A second medication is prescribed to treat it. The second medication causes its own side effects. A third is added. Before long, a patient is taking 6 or 7 medications, each one interacting with the others in ways that no single prescriber fully tracked. Keep those 3 things in mind as we go through the list. The aging brain is more vulnerable, the symptoms develop slowly, and the cascade effect multiplies everything. Let me start with the one that is sitting in the most medicine cabinets in America right now. Diphenhydramine, you know it as Benadryl. You also find it as the active ingredient in nearly every over-the-counter sleep aid sold in pharmacies. Zizquil, Unisom, Tylenol PM, Advil PM. It is the thing millions of older adults reach for when they cannot sleep. And they reach for it because it works, and because it has been available without a prescription for decades, and because it feels harmless. Here is a number that should genuinely stop you in your tracks. A landmark study published in JAMA Internal Medicine tracked 3,400 older adults over 10 years and found that those who took anticholinergic medications, the class to which diphenhydramine belongs, for a cumulative total of 3 years or more, had a 54% higher risk of developing dementia compared to those who did not take them. Not a marginal increase, 54%. Diphenhydramine works by blocking acetylcholine, the same neurotransmitter that Alzheimer's disease progressively destroys. Every time an older adult takes a Benadryl or a PM sleep aid, they are temporarily suppressing the very system their aging brain depends on for memory consolidation. The symptoms it causes are not subtle. Confusion, short-term memory gaps, difficulty concentrating, morning grogginess that extends well into the afternoon. In older adults, these symptoms can look exactly like the early stages of dementia. Exactly. What to discuss with your doctor. If you are using any over-the-counter sleep aid regularly, ask specifically about non-anticholinergic alternatives. Melatonin, low-dose doxepin, cognitive behavioral therapy for insomnia. These options exist, and they do not carry the same brain risks. The conversation is worth having. If you or someone you love takes medication for an overactive bladder, drugs like Oxybutynin, tolterodine, or sulfonacin, sold under brand names like Ditropan, Detrol, or Vesicare, this section is for you. These medications are among the most aggressively anticholinergic drugs prescribed to older adults. They are prescribed for a completely legitimate quality-of-life affecting problem. The urgency, the frequency, the fear of not making it to the bathroom in time, that is real, and the medications address it effectively. I am not questioning that. What I am questioning is whether the cognitive cost is being clearly communicated to patients before they start taking them. Here is what most patients are never told about Oxybutynin. Studies using brain imaging technology have shown that Oxybutynin actually reduces brain volume in older adults with regular use, not metaphorically, measurably, on a scan. Regions involved in memory and executive function show accelerated atrophy in patients taking these medications compared to those who are not. This is not a theoretical risk. It has been visualized on MRI. The American Geriatric Society's Beers criteria, the most comprehensive reference for medications that are potentially inappropriate for older adults, lists Oxybutynin specifically as a drug to avoid in patients over 65 because of its central nervous system effects. Let me tell you about a woman I will call Margaret. Margaret was 69 years old, a former accountant from Ohio. Sharp, organized, the kind of person who had never missed a bill payment in 40 years. Her daughter brought her to my clinic after noticing that her mother had started repeating questions she had asked 20 minutes earlier. That Margaret had gotten lost driving a route she had driven for 15 years, that something was wrong. Margaret had been taking Oxybutynin for 2 years for an overactive bladder. We worked with her primary care physician to transition her to a non-anticholinergic option. Within 3 months, her daughter called me. She said, "She's back. I don't know how else to say it. She's just back." Not every case resolves like Margaret's, but enough do that this conversation is essential. What to discuss with your doctor. Ask whether a beta-3 agonist medication like mirabegron might be an appropriate alternative. This class treats overactive bladder through a completely different mechanism that does not affect acetylcholine. It is not right for everyone, but it is worth the conversation. If you are finding this valuable, type the number 2 in the comments right now. This is the one that stops most people, not because it is shocking in principle. Most people have heard that sleeping pills can affect the brain. What stops them is the scale. Benzodiazepines and their close relatives, the Z drugs, are among the most widely prescribed medications for adults over 60 in the developed world. Diazepam, lorazepam, alprazolam, Valium, Ativan, Xanax, and the Z drugs, zolpidem, esopiclone, Ambien, Lunesta. Tens of millions of older adults take one of these medications every single night, many of them for years, some of them for decades. Here is the number that most of them have never heard. A large-scale meta-analysis published in the British Medical Journal, pooling data from over 100,000 patients, found that long-term benzodiazepine use was associated with a 51% increased risk of dementia. And a French study following nearly 9,000 older adults found that those who started benzodiazepines during the study period were 60% more likely to develop Alzheimer's disease within 15 years. Let me tell you about a man I will call Gerald. Gerald was 72 years old, retired airline pilot, precise, detail-oriented, a man who had spent his career making decisions in emergencies without hesitation. His wife brought him to my clinic because he had become confused about time. He would ask what day it was multiple times a day. He had started putting the coffee maker in the refrigerator. He had forgotten appointments he had written in his calendar himself. Gerald had been taking Zolpidem, Ambien, every night for 4 years. His internist had first prescribed it after a period of stress and had continued renewing the prescription at each annual visit without discussion. I want to be very precise here about what the research says and does not say. Benzodiazepines and Z-drugs suppress the central nervous system. They impair the brain's ability to consolidate memories during sleep, the very process that sleep is biologically designed to accomplish. Long-term use has been associated with structural changes in the hippocampus, the brain's memory center. Whether these changes are fully reversible upon stopping remains an active area of research. What I can tell you is that tapering benzodiazepines under medical supervision, never stopping them abruptly, which can be dangerous, should always be done in partnership with a physician, and that cognitive improvement following a supervised taper is documented in the medical literature frequently enough to make this conversation one that every older adult taking these medications deserves to have. What to discuss with your doctor. Ask for a full medication review with specific attention to sleep medications. Ask about cognitive behavioral therapy for insomnia, which has been shown in multiple studies to be more effective than medication for long-term sleep improvement. And never stop benzodiazepines abruptly, always with medical supervision. This is the one that surprises people most in this category, because proton pump inhibitors, PPIs, are so thoroughly ordinary that they feel impossible to worry about. Omeprazole, pantoprazole, esomeprazole, Prilosec, Prevacid, Nexium. These are among the most widely used medications in the world. They are sold over the counter. They are prescribed for acid reflux, heartburn, ulcers. Millions of older adults take them every single day, often for years, because their doctor once recommended them for a specific issue, and the prescription was never revisited. Here is the connection most people do not know about. PPIs have been shown to reduce the absorption of vitamin B12, magnesium, and calcium, all of which are critical for neurological function. Vitamin B12 deficiency in particular produces symptoms that are clinically indistinguishable from early dementia, memory loss, confusion, depression, difficulty with word retrieval, and B12 deficiency is extraordinarily common in older adults who have been on long-term PPI therapy, often for years, without anyone checking their B12 levels. A 2016 study in JAMA Neurology found that long-term PPI use was associated with a 44% increased risk of dementia in older adults. The researchers proposed multiple mechanisms, including B12 depletion, magnesium depletion, and direct effects on the brain's clearance of amyloid protein. Let me tell you about a man I will call Robert. Robert was 73 years old, retired school bus driver from Texas. His wife brought him to my clinic because he had stopped recognizing the names of people he had worked alongside for 20 years. He stumbled over words he had used his entire life. His family had started quietly discussing memory care. Robert had been taking omeprazole every single morning for 5 years, for heartburn. No one had ever checked his B12 level. His B12 was critically deficient. We supplemented aggressively under medical supervision. Within 4 months, his wife sent me a note. 3 sentences. He remembered our neighbor's name yesterday, without being told. I cried. Not every case is B12, but it costs 1 blood test to find out. 1 blood test. What to do? If you are on a PPI long-term, ask your doctor to check your vitamin B12 level at your next visit. Ask whether you still need the PPI, or whether the original condition it was prescribed for has been resolved. Many patients continue taking PPIs indefinitely because no one revisited whether they still needed them. Type the number 4 in the comments if you are still watching. I want to know who is here with me. This is the one the research shows is most frequently missed in cognitive evaluations of older adults, and it is missed because muscle relaxants are often prescribed for short-term use, a back injury, a muscle spasm, a specific episode of pain, and then continue to be refilled month after month because the underlying pain is chronic and nobody revisited the original plan. Cyclobenzaprine, methocarbamol, carisoprodol, Flexeril, Robaxin, Soma. Here is what the research shows. Cyclobenzaprine is structurally related to tricyclic antidepressants and carries a significant anticholinergic burden. The Beers criteria lists it specifically as a medication to avoid in older adults. Its sedating properties are well known. What is less commonly discussed is its documented association with confusion, impaired cognitive processing, and memory disruption, particularly in older adults who are also taking other medications with anticholinergic properties. The problem is the additive effect. An older adult taking a bladder medication, a sleep aid, and a muscle relaxant simultaneously may be experiencing a combined anticholinergic burden that far exceeds what any one of those medications would cause individually. No single prescriber may be aware of the full picture. The patient experiences the cumulative cognitive effect without anyone connecting the dots. Let me tell you about a man I will call Vincent. Vincent was 68 years old, retired carpenter from Pennsylvania, strong hands, quiet man, someone who had built things his entire life and took enormous pride in that. He came to my clinic because his daughter said he had become unreachable, not aggressive, not confused in an obvious way, just absent. Like a light had dimmed behind his eyes. Vincent was taking 3 medications simultaneously, a bladder drug, a nightly sleep aid, and cyclobenzaprine for chronic back pain from decades of physical work. No single prescriber had ever seen the complete picture. Each medication had been prescribed separately, by different physicians, at different appointments. We worked carefully with his care team to address each one. The change was not instant. It was not dramatic. But his daughter called me 6 months later and said, "Dad made a joke yesterday. I have not heard him make a joke in 2 years. That is the additive effect, and it is completely invisible unless someone looks at the whole list." What to discuss with your doctor. Ask specifically whether your muscle relaxant is still necessary and whether physical therapy, topical pain management, or non-anticholinergic alternatives might be appropriate. I want to handle this one carefully because chronic pain in older adults is real and serious and deserves to be treated. The goal of this section is not to suggest that older adults with significant pain should simply endure it. It is to ensure the cognitive costs are part of the conversation. Long-term opioid use, oxycodone, hydrocodone, tramadol, is associated with several cognitive effects in older adults. Opioids suppress REM sleep, the stage of sleep most critical for memory consolidation. They reduce levels of acetylcholine. They cause structural changes in the brain's white matter with prolonged use. And they interact with nearly every other medication on this list in ways that amplify cognitive effects. Tramadol deserves specific mention because it is often perceived as the gentler opioid, lower risk, less concerning. The research does not support that perception in older adults. Tramadol has serotonergic and noradrenergic properties in addition to its opioid effects, and its metabolites remain active in the body for extended periods. In an older adult with reduced kidney clearance, those metabolites accumulate. Confusion and memory problems associated with tramadol in older adults are well documented and frequently underappreciated. Let me tell you about a woman I will call Frances. Frances was 76 years old, retired librarian from New Mexico. Her son called my office in a state of distress. He said his mother had stopped reading, that she had surrounded herself with books her entire life, that her home looked like a small library, and she had not picked one up in 8 months. She could not hold a thought long enough to follow a narrative. Frances had been taking tramadol for knee pain for 14 months. Her kidney function, as is common in older adults, had declined enough that tramadol's active metabolites were accumulating in her system. Her cognitive symptoms were the result. After a carefully managed transition to a non-opioid pain management approach in partnership with her physician, Frances called my office herself 3 months later. She said she had just finished a novel, and then she laughed. That laugh is why I do this work. What to discuss with your doctor. Ask whether your pain management plan has been reviewed recently, whether non-opioid alternatives have been considered, and whether the cognitive symptoms you may be experiencing could be related to your pain medication. I promised you something practical. Here it is. The most important thing you can do right now, today, after watching this video, is request a formal medication review before accepting any cognitive diagnosis is settled. Not a casual conversation. A formal, complete review of everything. Here is exactly how to have that conversation. Walk in with a complete list. Every single medication. Prescription, over-the-counter, vitamins, supplements, herbal preparations, everything on the nightstand, everything in the medicine cabinet, everything taken even occasionally. Write it down. Bring it. Then ask the specific question. Not, could any of my medications cause memory problems? That question is too easy to dismiss with a reassuring nod. Ask this instead. Can you specifically review this complete list for anticholinergic burden and any other agents with documented cognitive effects in older adults? That language tells your doctor you have done your homework and expect a thorough answer. Ask about the Beers criteria by name. It is publicly available. You can look it up before the appointment. Ask your doctor whether any of your medications appear on it. Watch the response. A physician who knows geriatric pharmacology will engage with that question directly. That response is information. If you are on a PPI, ask for a B12 level, right then, at that appointment. B12 deficiency is extraordinarily common, almost always missed, and completely treatable. One blood test. And if cognitive testing has already been done and shown decline, if someone has already used words like early Alzheimer's or cognitive impairment in your presence, ask this before that diagnosis is finalized. Has my complete medication list been formally reviewed as a potential contributing cause of these results? If the answer is no, that review needs to happen first. A physician practicing good medicine will welcome every one of these questions. And if a doctor makes you feel difficult for asking them, that is information worth having. I want to leave you with something that I have carried with me throughout my entire career in geriatric medicine. A diagnosis of dementia is not just a medical event, it is a life event. It changes how families communicate. It changes how the person sees themselves. It changes what they plan for, what they hope for, what they grieve. It sets a trajectory in motion. That trajectory should never be set without first asking whether the medication sitting on that person's nightstand might be contributing to what they are experiencing. Not always, not even most of the time, but often enough, far often enough, that the question is not optional. It is essential. You have the right to know what your medications do. You have the right to know how they affect your brain. You have the right to ask whether the combination of medications you are taking has ever been reviewed as a complete picture. And if no one has ever had that conversation with you, it is not because the information does not exist. It is because no one had 15 extra minutes in the appointment. Now you have the information, and now you have the questions. Use them. If this video gave you something valuable, something you will carry into your next appointment or your next conversation with someone you love, please subscribe. I make videos like this every single week because the conversation you deserve is not always the one that fits in a standard appointment. And before you go, next week I'm covering something that I have had more requests about than almost any other topic. What actually happens to your body when you stop sleeping well after 60? Not insomnia tips. The real biology of sleep and aging and the specific changes that make everything, your heart, your memory, your metabolism, worse. You will not want to miss that one. Leave a comment below. Are you or someone you love taking any of the medications I mentioned today? Has a doctor ever reviewed your complete medication list for cognitive effects? Tell me what you think. This community reads these comments, and your experience might be exactly what someone else needs to hear. I am Dr. Harris. Take good care of yourselves. I will see you in the next one.